name calling, whatever.
Sean.
We are special, so.
Tell me if when I'm in the screen.
Oh, yeah, there you go.
Is that good?
Yeah, you're in.
Yeah. So we can, if you want, even get started.
You want me to go?
Yeah, I'm
Yeah.
fine with whatever.
All right,
Or I
I can go. I would like to
Okay.
get, then I don't have to be nervous for another 20
Yeah,
minutes.
do it.
All right. That's good. I don't know why people wait to get in these things. These are so fun, right? These are, they're good time. Yeah, I know. I'm sorry. Shouldn't have said it. I'm grateful to be here. Jamie actually kind of threw my name in there, and then I guess I'm here today. So I'm grateful for Jamie giving me the chance to be here. I know Medicare, Medicaid is like a super hot topic all the time, and I feel like there's a lot of information out there that's either misunderstood or people think they understand, but they really don't, or whatever. And so I believe a couple of years ago, I did a presentation for IGFA, and I really went over the basics of Medicare, which I think I'll do a tiny bit again today, but I really wanted to talk a little bit about what the heck is going on in the Medicare space. It relates to Medicaid a little bit. But I do things a little bit different on the Medicaid side than what Sean does. Sean's right doing planning and all sorts of things. I'm kind of just dealing with the health insurance plans that work with the Medicaid. And so I'll talk a little bit about what's going on in there, but how many people have heard of the Inflation Reduction Act? Yeah, how many of you think it reduced inflation? It didn't. I was just throwing that out there. Same thing with the Affordable Care Act. Do you think it made care affordable? It did not. So anyway, so I'm not trying to get political, but it does seem kind of funny how some of these laws get passed and they don't seem to like live up to what they're really trying to do. So the Inflation Reduction Act, I will say, the portion that deals with healthcare, I do think now that a lot of it has gone into effect, is doing a lot of good for a lot of people, but it has created a ripple effect on the insurance company's side that it creates its own challenges that it's like, great, like, cool, we got all these things going on over here, these benefits that we're able to take advantage of, but now it's all being reduced because the insurance companies can't afford it anymore. So anyway, so I'm going to talk a little bit about that. So I don't know why all the things are here, but we're going to go like this. So the Inflation Reduction Act was passed in 2022. It had to do with a lot of stuff. Wild guess on how many pages were in the act?
3,000.
Not quite. That's a lot though, but there's some that are like that. Any other guesses? More.
2,000.
730, right? Which is crazy. So I don't even think Congress read it, right? Truthfully, I don't, like, maybe this guy read these 10 pages or whatever, right? But the whole thing is, and it talked about energy and all sorts of things, healthcare, tax, there's some tax stuff in there. Anyway, there's a whole lot of things. So I tried to extract as much as I could out of the Inflation Reduction Act as it related to healthcare, because there was a 3 or 4, well, actually about a 5-year rolling out period for a lot of the things that were in there. So although the law was passed in 2022, we're not going to see some of the impact until 2027. Some of it has gone into effect though, and that's what I'm going to go over. So these are some of the things that have kind of taken place because of the Inflation Reduction Act. So one of the big things, and I have a couple slides on this, is prescription medication. So the Part D portion of Medicare that deals with medications, the way it used to work, you know what, I'm going to go to that slide and then I'll come back to this. The way it used to work was if you were on Medicare and you had a drug plan and it had a deductible, you would pay the deductible, pretty typical, right? A couple $100, some as high as $590. That's the max right now of a deductible. So the patient would pay that number, and then they would go into the initial phase, which is really the copay stage, right? So if a drug was $5 or $10 or $30 or $40, whatever, people would pay that at the pharmacy. They'd go home with their medications. And then when they hit a certain out-of-pocket limit, which prior to this year was about $5,300, they would go into another stage called the donut hole. Anyone heard of the donut hole? Love the donut hole. Anyway, glad that's gone. But anyway, the donut hole then made everything that was a $10 copay now a 25% copay. So if there was a $100 medication that was a $10 copay, it's now a $25 copay, right? There was an $800 Medicaid. Eliquis was a big one. So if anyone's dealt with Eliquis before, Eliquis is like an $800 medication, but people were paying $40 a month for it. And then it went to 25% in the donut hole. So people would call me in September and be like, Jackson, what the heck's going on? I was paying $40 for this thing. Now it's $200, you know? It's because you hit the donut hole. And then after the donut hole, they would go into the catastrophic stage where they would pay 5% of all their medications until eternity, right? Until January 1st came around again, and then the whole thing reset again, right? That's how it used to work. There was an eighth, for one of the years, which was last year, instead of the 5% thing, they went to a maximum of $8,000. So if a patient paid more than up to $8,000, then they were done paying for the year. And then it was great, like, cool, I'm finally done. But $8,000 for our seniors is wild, right? So they changed it. They got rid of the donut hole and they put a 2,000 max on drugs. That started this year. Wonderful thing, right? Who ate the $6,000? The insurance companies, right? Where'd they get the money? They didn't, right? They don't have it. So we all think they do, but they don't, right? And so, what we kind of saw, kind of going back here, what we kind of saw was some market frustration. So Aetna and Select Health on the Medicare side pulled their products last year. Well, this year, pulled them during open enrollment. And so all the people who had Aetna on these Medicare Advantage policies and Select Health, they were left stranded January 1st. If they had an agent, we were obviously informing them and letting them know and making all the changes as necessary. But if they didn't know, they were calling around in January figuring out what the heck happened to my Select Health insurance. It's gone, like it disappeared. What happened to it, right? Well, Select Health and Aetna made some decisions, right? Now, I don't know all the intricacies of why they made their decisions, but we know that it had, because of this Inflation Reduction Act, it had to deal with solvency, right? It had to deal with, the cost that the insurance companies are having to pay. So we saw some serious market frustration this last year, where I think it was estimated around like 25 to 30,000 people just in the Treasure Valley had to switch insurance this last year. So I'm sure some of you felt that with your clients and stuff. It had to get done, right? So that's been some of the impact here that we've had to deal with. But the goal of the Inflation Reduction Act, these pieces, was to reduce the cost to the seniors, right? Reduce the drug expenses. But then when you take the money out of the insurance company's hands and you say, hey, you guys now have to eat the difference, and they had a net deficit in funding for the last 2 years, they have no money. They got no money. They had to make their changes. So then what we saw was a lot of the companies who had zero deductibles. Now, guess what? They have like $400 deductibles now, right? Because now they're like, well, if we're going to have to eat this cost, we need to get the people to pay it now. So really, although they're getting this 2,000 max, they're actually having to pay more in some cases because the hand just shifted, right? Is this making sense? I hope this is making sense a little bit. So if you're wondering why the healthcare, especially in the Medicare Advantage space, particularly, not so much just the Medicare, but the Medicare Advantage space is such a mess right now, it's because the insurance companies are trying to adjust for all this extra cost that they have to pay, right? It's getting pretty hectic. We only saw 1 year of impact. We don't know what this fall is going to look like. So when we start talking 2026, we just don't know what to expect yet. So it's going to be very interesting as things go on. So keep an agent in your back pocket, because if you have a client that needs the help, they're going to need the help at some point. So okay, let's talk about, one of the other things too that was a part of this Inflation Reduction Act was this long list of negotiation for these really expensive medications. So you can see the list here. So starting next year, this is why we don't know what next year is going to look like with these insurance carriers, because we don't know, like, are the insurance carriers even going to include these drugs in the formularies? Are they even going to be covered? Are the negotiations, right? And let's think about this for a second, because I don't know the answer, but when the government comes and says, hey, let's negotiate, you think they're really there to negotiate? No, they're there to tell you what to do, right? And you're going to do it or you're not going to do it, right? Like that. That's basically what happens. So the government is at Eliquis right now in Jarden. So AbbVie and Johnson & Johnson, all these massive drug manufacturers, trying to say, hey, this needs fixed, right? Like, you guys are really expensive and people can't afford it. So we need to figure something out. So this will be really interesting with all of these medications to see what the next couple of years look like. But in theory, we're hoping they get low.
27 on the right-hand side. Never and I tried to pronounce them with 2 X's in it. I got to take that this year. 2 weeks with $1,000 out of pocket.
Yeah.
Well, now, wait, we're talking about the future, right?
Correct.
What about the latest cutbacks in Medicare and Medicare as it is? The new ones are gearing for Trump put it in.
Yeah, great question. That technically, as far as right this second, there has been no impact. there's a lot of talk, but there is no impact yet. Right now, if we're going to see impact, typically, and I would imagine if we're going to see impact anywhere, we're going to see it in Medicaid first, because it's the state, right? We're talking government to government, feds to the states, right? I think if anything happens, the states will feel it first. The insurance companies and Medicare and all, and that system will probably feel it if there are epic changes in the next 3 to 5 years, just like we saw with the Inflation Reduction Act, right? The Inflation Reduction Act included all these things, but it said for the Part D changes that went from 8,000 max to 2,000 max, that change didn't happen until 2025. So it took 3 years for some of this stuff to institute, because there's some logic, I think, understood in the government side that says like these insurance companies need some time to adjust, right? They gotta, yeah, they're dealing with billions of dollars, but billions of dollars coming in, billions of dollars going out, right? And a lot of these companies are in a net negative as of late. The insurance companies that are doing really well right now are life insurance companies, right? Because they pay out like less than 6% of claims, whereas health insurance companies by law are required to spend over 80% of dollars on claims. If not, they have to increase benefits or give money back. So the government has actually forced the insurance companies' hands. Like you can't just make money hand over fist. If you have a great year, you got to pay it back because it's all government dollars, right? So they don't have a whole lot of control over that. And so most of them are having a net negative, which is why we're seeing some suffering right now. So, all right, what else do I got on here? Okay, let's talk about this for a second, because my next slide, this will make a little bit of sense. So when somebody is eligible for Medicare, you are eligible for 2 types of options. So there's like 3 or 4, but really there's 2. The one option is you could take the red, white, and blue Medicare card and never get anything else. You can never get a supplement, never get an advantage, don't buy a drug plan. You could avoid all of that if you wanted. You're going to face penalties, but you could do that, right? Not the best coverage on the planet. It's okay. It's good enough for most scenarios, but it could be catastrophic for some others. So, and let me explain the catastrophic of this. Let's say someone takes Medicare and they never add a policy to it, and they get cancer, and they rack up $800,000 worth of chemo treatment, right? They're going to pay 20% of the whole thing. There's no max out of pocket with Medicare, like original Medicare, right? The red, white, and blue card, there's no max out of pocket. So 20% of the whole bill is what they're on the hook for. That's why there's an attractive nature to these policies, is because it's from a risk standpoint, it's protected. People have feelings on these policies, I get it, but it's a protection. If we're talking risk, it's a protect. That's what these insurance companies are all about, is risk, and protecting. So what people can do is they can buy a supplement insurance, and the supplement is designed to work in addition to the Medicare, not replace it, but in addition to, and it's there to pick up all the stuff Medicare doesn't pay for, right? So if there's a deductible, if there's a 20%, if there's a hospital charge or whatever, Medicare pays the first portion. The supplement comes in and swoops up and picks up all the rest. That's the typical design of a supplement. They're kind of spendy for one of the most coverage ones you can get. They're like $220 a month right now, in addition to their Medicare premium that's $185, which goes up every year. In addition to the Part D drug plan, because they're all separate. So you have drug plan, supplement, and Medicare. So 3 cards in your wallet doing 3 different things. That's what one of the options is. Okay. The second option, which typically tends to be the most popular, in a lot of cases advantageous for a consumer, is a Medicare Advantage plan. These are the ones that people have feelings on because it's a replacement of original Medicare. So the insurance company basically gets contracted by Medicare to become the Medicare for that person. So they take over all the hospital charges, all the doctor charges, but in turn there's co-pays, max out of pockets. That's where the protection comes in with these. There's networks they got to deal with, whatever the case may be. That's where a lot of people have issues. They say, oh, I got this policy and it didn't cover my doctor. And it's like, what the heck? Medicare did, so if you had a broker though, that wouldn't happen, just saying. But anyway, so these advantage plans can be a lot more advantageous because most of them don't cost any extra. Some do, but most of them don't cost any extra dollars. So you pay your $185 to original Medicare to have the Medicare, but these policies don't cost a whole lot in addition. So somebody who's only making $1,200 a month, you think they're spending another $220 on a supplement plus another $50 on a drug plan? Probably not. So they go to these advantage plans, and 9 times out of 10, they work extremely well for people. If someone's rather healthy, maybe has a surgery every year or two, your out of pocket's not terrible. But there's a situation like yesterday where a client needed to go to Utah, but they had a policy that only works at St. Luke's, right? So it's like, well, you're restricted. You can't go to Utah. So we had to do some finagling. We got it fixed. But that's where some of these restrictions can come in. But that person didn't know they couldn't go to Utah. So no one educated them. So they need the education. But nonetheless, the reason I'm bringing these policies up is because in the Medicaid space, which Sean will talk a lot more about, Medicare Advantage, which is what we talked about here in some of those things. When somebody obtains Medicaid, they can really do one of two things. And it really depends on the level of Medicaid. If they get what they call a Medicare savings program, you're going to talk about this a little bit. If they get just a Medicare savings program, they don't qualify for the MMCP policies, the Medicare Medicaid coordinated plans. They don't qualify for those. You have to have enhanced Medicaid to get that. So that's what this middle section here is for, is people can do one of two things. They can either keep a normal Medicare Advantage plan, a non-MMCP, meaning it doesn't coordinate with Medicaid. It's just a normal Medicare Advantage plan. And then they'll get a health and welfare card that's actually contracted through an insurance carrier. So that's where Blue Cross and Molina come in. If you've kind of wondered, like, well, how's Blue Cross and Molina in the Medicaid space? How's this working? This is where they're working. They're in these people are in an enhanced level of Medicaid. So they get a Molina or a Blue Cross card that only does Medicaid.
This is what people have heard. You no longer have Blue Cross, they're gone, right? United Healthcare's coming in. So they're the new one in January, right?
So what's confusing is they could have a Blue Cross Medicare Advantage and a Blue Cross Medicaid. So if they lose Blue Cross, they're probably just losing this, but they can retain the Medicare. Confusing,
Yep.
but clear? Or is it,
Nope.
no? Right. So I guess before I go any further, is there anybody here who doesn't know the difference between Medicare and Medicaid? Anyone who doesn't like
I don't really understand it.
Medicare's federal, it's the FICA tax you paid your whole life, goes into Social Security.
Okay.
You hit a certain age, you get a federal card, it's your health care, right?
Okay.
Medicaid, for lack of a
No,
better
I-
word, it's for low income.
Medicare.
What's that?
I got United Health, but that give away my Medicaid.
That's your Medicare Advantage.
Yeah, that's my new.
Yeah. So Medicaid is for low income and it's state-based, not federal.
Okay, no,
Right.
I'm talking about federal.
Okay, yeah.
Medicaid also is just a giant umbrella, a dozen different programs that people
right.
talk about. I'll walk through the most important ones today, the most common that we see.
Sure.
But Medicare is kind of the health insurance you get either 24 months after you become disabled and you pay into those benefits and qualify for them, like SSDI, or at age 65 when you
That's what I
qualify.
got. It's
Okay.
like, that's Medicare.
Medicare.
Care.
And now it's United Health, they get to check with Medicare to do that. They can-
Right, which is Medicare Advantage. Yep,
Yeah.
there's a replacement, yep.
And
That's right.
if you can stay off Medicaid, do it. Stay away.
Well,
That's my presentation right there.
Yeah. Just don't do it.
Stay away.
So people can have the choice to keep their Medicare and Medicaid separate, which is why there's two cards here, right? Medicare pays the doctor first, Medicaid comes in, picks up the difference. Unless you have enhanced Medicaid, then it's gonna cover a whole lot more that Medicare doesn't cover. Or you can combine the two into a DSNP, or what they call an MMCP. So Medicare, Medicaid coordinated plan, or dual special needs plan, basically the same thing. But it's where they take the two policies, the Medicare and the Medicaid, and they fuse it into one policy. And it looks a lot like just this, but it's got all the Medicaid coverage inside of it, right? It's just a Medicare Advantage policy with a bunch of Medicaid inside of it. Why some of them will do those policies for various reasons is because it makes it simpler for the client, right? They get one card in their wallet that does both Medicare, Medicaid, rather than having a federal card and a state card, right? Can make it simple for them. There's also some extra benefits built into those. Some of them come with dental and vision and gym memberships and over the counter dollars and like FSA dollars type of thing. So they come with a lot of these things that are attractive to these people, right? Some of them are getting a couple $100 a quarter for, buying aspirins, and, some of them will pay for Uber rides and stuff. There's just a lot of stuff here. So, yeah.
And silver sneakers. When they do a combination of the two, is that an income restricted placement? Is that why they would do that? I mean, why would somebody that qualifies for Medicare and doesn't necessarily with Medicaid, why would they do that combination, or what client profile fits that?
There are programs that Medicaid has to help pay for the Medicare co-pays, deductibles, premiums, the things that if you're on a really limited budget, really limited income and resources, then the Medicare Savings Program, which is administered by Medicaid, very confusing, but that's where the Idaho Medicaid can come in and help people qualify for, to get some of those co-pays, deductibles, and premiums covered.
So if you don't have the income to do a supplemental plan, and you're on the opposite end of the spectrum, but you still have Medicare, getting that combination would help supplement that differential.
Yes, or if, when he said earlier, if you need enhanced benefits, what does that mean? Enhanced benefits means if I need in-home care, if I need anything that crosses the line into long-term care programs, that's where Medicare, that you got your 20 days in rehab, and then you're paying your copay thereafter. That's where Medicaid can kind of come in and help pick up the slack for people.
So it is income restricted.
Income and there's asset and income restrictions, and there's levels to it. And I'll walk through it all with you guys in a minute as well.
The key here is that there's just a ton of options that are given to these individuals, right? And if they have Medicaid, they get more options. And so there just needs to be navigation to go through what options are on the table for them, right? Not every policy is the right fit for everybody, right? These DSNP, these MMCP, there's so many different acronyms for these things, but those policies are done by only two companies that are contracted with Medicaid, and that's Blue Cross and Molina. So the only ones that are available are those companies. But after this slide, I'll talk to it, but yeah, please.
So, will United Healthcare also be required to have care managers? Because I know that
Yeah.
that's one of the features that these dual eligibles have.
Yeah, so they absolutely will, because they're taking over, they're contracted Medicaid. Medicaid says, I'll just pay a company to do it and we won't do it, right? But they have to do it. They have to do what Medicaid says they have to do. That's the rule, right? Or else they can't be a
Right.
contracted provider.
Right.
So they're gonna do everything, right? And typically, you would think, because it's private, they would do it better than the government would, right? In a way, you would hope they can manage the dollars better or whatever. They can provide maybe more services and whatnot, but it takes a lot of load off the state too, because it says the insurance companies are already doing this. Let's just pay them to do it, right? Blue Cross lost the Medicaid contract. Sure, some of you heard about that. That's gone June 1st. So anybody who's on one of those MMCP policies, they're losing it. June 30th, May 30th, geez. May 30th is the last day they'll have that coverage. June 1st, they'll be back to it. They'll be reverted, unless they do something, they'll be reverted back to original Medicare, the red, white, and blue card. And then they will get one of these cards from United, because United's taken over that contract, United or Molina, to just do the Medicaid piece.
Do we know if United's gonna actually start in June as well? Or
They're-
are they
Great question.
still up in the air?
They are starting June 1st.
Oh, wow.
Their contract starts June 1st. They will be in operation. I was just at United training a couple weeks ago. They talked all about, they had the Medicaid guy in town. They talked all about it. They are taking over day one. So a lot of the people who had Blue Cross, if they didn't make a selection, they're going to be auto put on United Healthcare, right? Now, anything about United Healthcare related to their Medicare product does not relate to this Medicaid product. This is a Medicaid product, right? This isn't Medicare. This is a Medicaid product that they're taking over. Now, come January 1st, they will have an MMCP product, one of these DSNP options. They will have one of these Medicaid coordinated plans available. They can't start those mid-year. Medicaid can, because it's a state deal, right? But from a federal standpoint, they can't start a plan mid-year, so they have to wait till January. Come January, United and Molina will be the two MMCP options available to these folks. So.
They're getting different dates.
Yeah. Yeah. So if someone says, oh, my Blue Cross was replaced by United, if they were in a Blue Cross MMCP, the United is not replacing that. United is only replacing the Medicaid piece of it. The Medicare piece will then be done by original Medicare, or the people will have the option to add a Medicare Advantage plan if they want to replace the original Medicare with one of those.
Beneficiaries are going to be notified.
Oh, they've been notified.
I mean,
Yeah.
coming closer to January 1st as well.
Yeah, I don't think they'll be notified of the United Healthcare MMCP. That's a marketable product, meaning it's an agent's ability to go and sell that thing, right? So we will be out marketing it probably, right? You know, saying it's available. If you want it, come talk about it, whatever. But it's not a requirement. They don't have to go with them. The only reason people go with these Medicare coordinated plans is sometimes it's simpler for them and sometimes the benefits make it so. Like I have a gal like Melina, to give an example, they give, if they qualify, they get $150 a month food card. No one else is offering that. Right. So someone might say, well, I don't like this Melina benefit over here, but if I change to a new company, I lose my food card. I'm not leaving. Right. So some of these people are getting $3,000 to $4,000 in extra benefits that they don't want to walk away from because it's more than Medicaid's giving them. Right. In some cases. So it's tough. It's a tough battle.
Yeah, the math is different for everyone.
Yeah.
So lining it all up and figuring it all out, having a broker is helpful for that. But our office definitely does not do that.
Yeah. And it's needs based, right? So if someone comes in the office, we're sitting down, we're asking them questions, we're asking every medication they take, every doctor they go to. We're asking, you know, what do you need? What do you hate about your plan? What do you love about your plan? Whatever. And we're doing the best we can. Sometimes though, if they're saying, no, I want one of those MMCP plans. I want one so bad. I want one. Well, Melina's your only option after June 1st. So I can either pigeonhole you into that policy or I can leave you on original Medicare or a normal Advantage plan, right? With the Medicaid add-on or whatever, and get custom with these people. So anyway, that's where I come in. I always tell people I'm like a guide in a corn maze at night with a flashlight. We're just there to kind of guide people through the program. It really doesn't, I mean, a lot of people think I'm a sales guy. I'm really not a sales guy. I'm just here to like guide people, right? These are your options. Here's the education. So yeah. So anyway, I think that's all I have. Oh, there's my ugly mug. And that, if you scan that, that's all my contact info, but I can give you my card too, whatever you need. So,
Do you have internet access on that?
I can watch this.
So we want to go, you could go there. I know exactly what it is. I'll give you this. Okay, so what I'm gonna do is I'm gonna go ahead, Mary.
When Blue Cross goes away, we automatically, for those that have Medi plans, they'll automatically be enlisted into United Healthcare, but Melina still plays a part, and that is what is so confusing to me.
So maybe you have something on this. Don't worry too much about that, truthfully, because if they don't choose one, the state will pick one for them. They're going to get the same result. The coverages on both of the Medicaid plans are identical because they're contracted from the state with the same contract.
But you could never get a hold of anybody at Molina. And as a guardian, I get so frustrated because there's so many different divisions and they don't have my paperwork.
Yeah.
So I can't talk to you.
Yeah, so I would tell you that a broker would be an invaluable piece of that equation, because as a broker, we have access to local broker managers who have inside access to client information. We can get things solved. Like if you can't call the 1-800 or get a thing solved, I can call my lady down the street, right?
Turns out it's who you know.
Yeah, amen to that. Yeah, that's the truth.
So I'm gonna jump in here on the end of this and just give everybody a little bit more info on what I see. Because I don't sell insurance. I practice law and I do a lot of Medicaid planning for people. And part of that is me saying, well, here's the benefits you get for this Medicaid program, but what are the results? What are maybe the negative aspects to it? And the one thing that I'm seeing a lot with these dual eligible programs, so the Medicare, Medicaid coordinated plans in Idaho, is that, well, people don't understand that what they're getting into. They may enjoy it. Maybe they're getting great treatment from it, and that's awesome. A lot of people do. But a lot of times people end up amassing a giant estate recovery claim against them later. And so for some of us, fine. If some people, if they're kind of out of assets, really low on assets anyway, they don't really care about passing anything along and they need this stuff, great. Then Medicaid estate recovery is a huge deal for you. But there are a lot of people who do want to pass on a little bit, or maybe they've made deals with their kids that Medicaid doesn't know about. And so I get cases where a house gets bought on contract and 10 years later, Medicaid can come back and say, no, that wasn't a fair deal. So it can get really messy. You got to be aware that if you're on these these MMCP plans with Medicare and Medicaid, then there will be a state recovery attaching to those, and it's different for each one. Some of them are, some of them, I'm out of the, okay, some of them you get what's called a per member per month capitation rate. So that's regardless, if you don't do anything, let's say you never go to the hospital, you don't use any of your benefits, Medicaid's charging you a couple $1,000 potentially each month just for having that coordinated plan. On those same plans, like if that's probably a bad idea if you weren't using it, but if that same individual then goes into a facility that's $9,000 a month, it might be a great benefit to them because they're only paying this minimum capitation rate and not the full facility amount, and the insurance company's picking it up. So we're getting long-term care enhanced benefits from that. But what you gotta be careful for, and I catch Medicaid doing this all the time, is they try to charge you for both. So you have, after, when the estate recovery process, you gotta ask them, you gotta dig into, well, what were they on? Cause they just kind of throw the whole bill at you. So in addition to,
I think we're good now.
so we talked about we were just talking about this, the MMCP, the shared plan. I want to talk about, so there's, this page right here is my friend. It's your friend too. Health and welfare.io.gov, the Medicaid program and income limits. This is kind of the page that lists your main Medicaid programs and services. The ones that we've talked about today are so far is this one, the Medicare Savings Program.
You can click if you want.
And I'll open it there. Okay. The great thing about this program is it provides some help for your Medicare co-pays, deductibles, premiums, but Medicaid estate recovery doesn't get to come after this stuff when they pay it. So a lot of my clients, they only need this, and they don't need that enhanced. They don't need the enhanced benefits, and they don't need to get pushed on the dual eligible program, but they get signed up anyway. And I understand why. Medicaid's job is to find people that are in need and sign them up for programs that they need. I get it. But in the push to try to help folks, that some people get pushed onto these programs they don't need. They get a per member per month capitation rate against them. And then I get a call saying, oh my gosh, I found out Medicaid says I own 20,000. I've never used Medicaid. How is this possible? And then that's a tough discussion. Then we're calling and we're negotiating and we're trying to figure out if Medicaid will play ball with us. So the Medicare Savings Program is one that is not to be afraid of. This is one that if you have a client who has trouble paying their monthly copay, deductible, premium, look at this. If their income is at $13.25 a month, they get a lot covered by that. This is of the Medicare Savings Program. There's several levels to it. This is kind of the best level, the most coverage level. So if you have less than $9,660 in your bank account, and you make less than $13.25 a month, they will pay Part A, B, C, premium, deductible, copays, etc. It's not against, it doesn't go against your estate. So we got to look for that for your clients and think, man, this guy's really having a tough time making these bills every month. If they've got to look, is there anything I can do you can also do Medicaid planning. What can I do to change his income? Has he got an IRA that's just pushing him over this a little bit each month? Maybe do the math. Maybe it's worth it to get rid of this $20,000 IRA. Yeah, shift that asset to something that's exempt and then now we help him out for the rest of his life.
Can they still qualify for this stuff if they have like a special needs trust?
Yeah, so the resource limit right here, this is non-exempt asset resources. So an IRA where you're taking your required minimum distribution is excluded under the Medicaid rules. Like a special needs trust, if you're under 65, you can put money into that trust and it's excluded. An even better trick, which is cheaper, is the ABLE accounts. So if your client was disabled prior to age 26 this year, in January 1, that goes up to 46. So age 46, disabled prior to that age, then you can throw in 19 grand a month, 19 grand into that account. It's like cheap. It's like $25 to get it done, set up. Idaho should have one soon from Ohio. They're coming to help us out. Ohio's been the best for most of my clients over the years. But yeah, open an ABLE account. If you got 20 grand, open it and you qualify, open an ABLE account, throw it in and you're under this limit and you're on. And then you can keep putting money in there every year and managing it for your client.
Qualifying age went from 26 to 46.
Yeah, it will go January 1, 2026. This is a lot of sixes.
That's a huge.
I know, and it's kind of a number
You
pulled
have
out.
an able account for medical needs
Yeah.
or.
Yeah.
Is that just with Able or is?
Yeah, this is the ABLE account. The ABLE account has an age limit right now, disability onset date prior to age 26. In January 1 of next year, it goes up to 46. The other thing that I mentioned that they said was special needs trusts. Those have a first party special needs trust. So if it's my money, it's first party money, that has an age limit of 65. So you gotta be old, you can't be older than 65 and put money into that account. But this is the kind of stuff that I get a lot of elder senior clients that we do planning for, where there's another dozen strategies that I won't confuse anyone with today for Medicaid planning. So the next one this next select section, 1,500 for a single individual, 85 is the income limit a month. That part pays your Part B and D premium, deductible, and copay. So it's still a significant amount, several $100s a month for a lot of people that ends up saving them, which is a lot when you're on a fixed income. And then the last level is the QI, the qualified individual. 1,781 is the income limit for that, and it's just the Part B premiums only for the most part. So that one is one I think that you guys, a lot of people qualify for, not a lot of people realize it, and so they don't apply for Medicaid, thinking that there's nothing that they can help you with. The Medicaid program that we hear about the most is this one. This one is just your Medicaid adult, including the expansion program. So it's the Obamacare, basically. It's the insurance for people who are low income. It just looks at your income, your modified adjusted gross income. Says if you make average of 1,800 or less, you're in.
Just to be clear, this is non-Medicare.
Correct. This is not Medicare.
This is if you're eligible for Medicare, you are not eligible for this.
Correct.
Because then you go into the Medicare savings program sector.
Yeah, Medicaid is what they call a payer of last resort. It means we have to make sure we have to look at everything, anything else that you have first, and then Medicaid.
And it goes back.
Medicaid will
They
step in.
actually go back and look at your.
This one, yeah, the expansion stuff that if you're at a low income families, it's pretty common to see those. During COVID, this shot way up when people lost jobs. And then Idaho, I think we were probably top of the nation for per capita. They got kicked off Medicaid just last year when they finally undid all the COVID help and restrictions. So a lot of people lost their insurance at that point. If you're under 65, this is usually where this is how people that are really income challenged are getting their health care paid for.
So you mind if I chime in just?
Yeah, please.
So this sector of Medicaid is not asset based, it's income based only. So if I have someone, I have had this happen multiple times where I got a client who's 62, retired early, was making $300,000 a year, lost a job in April or March or whatever. He's now making $0 a month. He's qualified for Medicaid. And he may have $1 million in the bank, right? He may have a couple houses or whatever, but so now that's because he's 55 plus, then
Yeah,
he's subject to a state
Warning.
recovery.
estate recovery.
What did you say again? Which one's income based only?
This one,
This one is?
the insurance. This is adult Medicaid
Insurance.
insurance. Yeah. Go ahead.
As an example, I've got a daughter, son-in-law, and a number of grandkids in Bush Islands and Papua New Guinea, in the Wedu tribe. Insurance companies don't want to cover them, and they're low income. So they qualify under this, and eligibility actually worked with hospitals in Australia where they would go, that they temporarily become Idaho hospitals by contract, except the dollars. So the eligibility has been very good about working on this in very unusual circumstances.
Interesting.
Yeah, the biggest issue though, I see again for this case is people that, I've had clients that, they had a big business lost and it lowers their income when you look at what their, year over year, when they push out their losses and their insurance broker tells them, oh, you qualify for Medicaid, you don't even need to pay for any insurance right now. They don't tell them all the time about what Jackson warned you about is Medicaid comes after you after age 55. They're keeping track of every dime they spend on you. And your spouse, and they will come after it. And if you gifted an asset away, it doesn't matter. You're kind of out of luck.
So if you're 54, you're good.
Yeah,
Take advantage.
don't age if you can avoid it. Yeah.
State recovery is so reasonable to work with.
Yeah. There used to be a guy over there, Corey Cartwright, who was extremely reasonable. and times have changed. They're a little more aggressive. I think Idaho really does pride itself in being one of the highest per capita state recovery states in the nation. And they don't miss a ton. They fight pretty hard.
I could be wrong. I don't know how your feeling is on this, but like, out of all the states, I feel like Idaho's the only one that really doesn't want Medicaid at all,
Correct.
right? Like they have to because the feds say so, but if they could say, we don't want this, they wouldn't do it. Am I wrong on that? I mean, I don't know how you probably have a better feeling on that.
Well, I do, so we probably do, how many, Ann helps us file probably 5 to 10 Medicaid applications every month for clients. And they will if they just don't like something, if you're saving them too much money and helping them out too much, which really it's no different than tax planning or bankruptcy planning. We're using the rules that exist to save someone money and get them the help they need. But Medicaid gets mad and they will intentionally break one of their own rules, deny our application and force us to appeal. We have 2 appeals right now that we have to go through. And they've told us, we don't care. You're gonna have to appeal us.
Why did the legislature fight Medicaid expansion? 90% federal dollars coming in on the land. And it took years and years to get it here.
Yeah. Undone like that. Yeah.
I'll go ahead and ask my question, and I know there's a couple people here in the room who have the same question. So there's a person and her name is Jane, and she 3 years ago quitclaimed her house to her neighbor for nothing, and then over the next couple of years, $2,000 or $3,000 a month was conveyed out of her bank account to her neighbor. She went from 200,000 to 50,000, and now she's got close to zero. And so all of that is within the 5 years. And her attorney said, well, she didn't do it to avoid Medicaid because at the time she wasn't planning on being on Medicaid. Her intent was to make sure her greedy sister didn't get it. And she wanted to make sure it went to her neighbor. But now she needs Medicaid. So if she applied for Medicaid in the next week or so, and her house and her bank account has all been transferred to her neighbor, what would you think their reaction would be?
In Idaho, she's being denied.
Yeah.
Flatly. I have a case now where we got some money and put an ADU on daughter's house, with the intent to avoid Medicaid forever. Then mom fell and broke both hips. And Medicaid says, we don't care. That money that was spent to get that ADU, was obviously with Medicaid planning in mind. Well, it clearly was the opposite. We were trying to live off of Medicaid. But if you were tell her my advice to her would be to move to California or Washington.
What about Oregon?
Oregon's probably a little bit better than Idaho, but I don't think that I don't know if they're that nice. And either way, Medicaid's gonna come take that. She could use Medicaid and then they're gonna track that property. They're gonna go take it from the neighbor later. So I would say, let's return that gift, cure the penalty. Let's get her the help she needs. The sister doesn't get it, Medicaid gets it. And then everyone's happy.
The house is an exempt asset anyway, so.
Yeah.
If she can get home care, all she has to worry about is money in the bank, and she can do improvements to the house and whatever. So, I mean, there's ways that it worked out very well for her.
And I can say we just finished a 3-day trial last week trying to get all of those transactions.
Yeah,
reversed.
well, if that's one thing that Medicaid Estate Recovery will do. If you call Jeremy Youngren and say, hey, I got these, we need to get this back. He's willing to get his teeth out and scare someone to give some property back. I've had cases of exploitation where we have signed our rights over to them for recovery, and I took an RV and drove off and left, and we just sent Medicaid after them. So
I'm the guardian ad litem.
Oh.
On that case.
That hypothetical.
Now, so it'll be very, very interesting.
Who's your judge?
Brent Ferguson.
Elmore.
Oh, okay. Brent, former Ada County prosecutor, former
Yep.
police officer, good dude. Brent's awesome.
Corey, maybe you can help me out with this question, because I won't be able to articulate it well. In the goings on of this case, opposing counsel had some sort of solution of how we can, and how my client actually, could in fact get a little bit of Medicaid. And do you remember that weird, we think it was a misquote and a misunderstanding of.
Was it a hardship? Was that it? Or was it a?
It just does for as long as this was, do you remember it all, Corey?
So Corey mentioned, as long as it wasn't done with the intent of Medicaid planning in mind, there, so that's one of the exceptions that Medicaid, well, it's in the code, but it's in their, it's in their discretion, and they're gonna say no every time unless you really prove it to, usually to an appellate body beyond,
And of
well-
course, now she's incapacitated, so that's
Uh-huh.
happening.
yeah, I mean, this is a case where I would say, if you can assign recovery rights and get Medicaid on board, this, the neighbor doesn't deserve it, unless they helped out, then let's get Medicaid paid and let's get that person taken care of. We're not saving any, like, you can gift, there's a dozen strategies to get eligible for Medicaid. And most of my cases, I'm looking at, who needs help here? I got a disabled child. I can gift to a disabled child without penalty. I can create a trust for that child and gift to it without penalty. I can spend down on the house. There's a lot of things you can do. You can do caregiver agreements with family members. We can make sure that our professionals get paid. We can pay ahead a little bit on some of that stuff without Medicaid balking at it. Because a lot of people, eventually you're gonna run out of money, and who's gonna be the guardian now? Those cases are the worst ones.
If they couldn't do that.
For like, it depends on how much. So I've got, if,
Anything is helpful.
yeah, there's no rule on point on it. But if it's not a family member, Medicaid's a lot more lenient. If it's a professional, Medicaid's gonna be a lot more lenient. And we could draw up a contract, and say, look, this person's going to be my guardian and I'm probably gonna live 5 years. Let's pay for that guardian for 5 years. And if we could ask for permission versus, versus forgiveness, then a lot of times you can get Medicaid to play ball on that. But if you just do it and pray, if it's a family member, especially, it's gonna be a no every time for family members. But I think with professional guardians, fiduciaries, there's a chance you can do a little better for it. Go ahead. Yeah.
We'll call her Jane.
Another hypothetical person. Jane's a problem.
To put her there, but she's in love with a scammer.
Who isn't? Oh my goodness.
It's at a place where they're about to need more than their own assets will afford,
Mhm.
and I have no idea what to do. Income might be like six-ish a month, but that's not going to cover the type of care I think she's gonna need.
Not when your memory care is average 8,000 a month. So scamming, I've had a lot of scam cases. Those ones are tough ones. If we can get the money back, great. If not, Medicaid does want you to assign. Yeah.
Oh my God.
Medicaid wants you to, if you assign the rights to it, you can kind of get a police report, show that you've taken some efforts to try to get that back, then your chances of success with Medicaid go way up. So police reports is where you start for sure. And then anything else you can do is helpful. Switching gears a little bit here. So there's a program that a lot of folks don't know about that I wanted to chat with everyone about today and just bring to your attention, highlight it a bit. And this is the Medicaid for Workers with Disabilities program. So I've got a lot of clients who they want to work and they want to stay busy as much as they can. But they have really grave disabilities and serious special needs that require like in-home care 24 hours a day, where they can't do both. They can't go on total Medicaid, the waiver program and get all that help and work at the same time. They don't think they can. This program lets you do that. Medicaid for Workers with Disabilities gets you the insurance piece of Medicaid. It also gives you the enhanced Medicaid benefits. So like the Indy waiver, in-home care, facility care. things like that. I mean, finding a caregiver is the next big hurdle after that, which you guys all know. But at least we're in and we got the door open and now we can start planning and creating that for somebody. The fantastic thing about this is it's only it's a premium based program. If you're earning up to $17.55 a month, it's a $0 premium for all that. They do start, if you're using the enhanced program, they do start to tack on some co-pays after a while. Which you can try to push down a little bit with them, but I mean, you can make as an individual, you can make $65.41 a month and get that. I've got a client now that does. He makes really great money. But he needs 24/7 care, and this allows him to do it. Eventually, you always go off Social Security at some point if your earnings is above the substantial gainful limit, which is 1,600 or so right now. Yeah, unless you're blind, they got a good lobby.
This is an age limited, I assume.
It does have an age limit. That's a great question. 64 at 64, or 65, excuse me, you are aged out of that. Yep, and most of the time you're going on to, usually you can avoid having that copay on this, but once you hit 65, they're gonna push you to the waiver program and now you're gonna have a bigger copay. Unless you can try to push it down for them.
What is that?
So this one is Medicaid for workers with disabilities. Yeah, you can have $10,000 in assets that are outside of any trust or not otherwise non-exempt. It's one of the more generous ones that Idaho has, so keep that in mind. And then the last one that we'll chat about, what are we at on time? Help me out here.
15 minutes.
15 minutes, perfect. So the last one I want to chat about is, there's a lot of great ones here. Look at this page someday and click around it and introduce yourself. But the long-term care, the waiver services, home community-based services, there's also with the DD waiver program, if you've heard about that. I mean, this is the one where when we really run out of assets and we need in-home care or long-term care in a facility, certified family home, a rehab facility, that sort of thing. This is usually how they're getting it, is through the aged and disabled waiver. I mean, they have both of them on here. They're the same umbrella, same program, same application, and they transition into each other. We'd love to stay in our home as long as possible. When that doesn't work, you're still on the aged and disabled waiver program and you get pushed right into the facilities. But the income limit for that to be aware of is $29.21 a month. It's easy to get around if you're over that. Just use a Miller Trust if you can't otherwise lower your income with some planning mechanisms. Hey.
So if somebody is going into assisted living, maybe they're on Medicaid but not using disabled, like how do they do that transition to?
We usually call Medicaid and say or the facilities even will reach out for us a lot of times and say, is he on Medicaid? Yeah, okay, well, we're gonna go from home community, we're going in and they don't relook at anything. That's not a reapplication. They're always looking at your income and assets, but you don't have to reapply and go through the scrutiny of the application. The first application is usually the hardest one. But it's, again, for this one, the resource limit, how many assets you have, that's usually the hurdle for most people. And there's a dozen different strategies. How can we prepay for things, get shipped assets to an exempt source and get on Medicaid sooner and save as much money for them as possible. There's intentional gift penalty strategies that people use a lot. If I could have just a little bit of extra money to help pay for mom's, get her hair done and maybe get a better room for her, if she's at a shared room with a shared room facility on Medicaid, then we're going to do that. So good to remember that. Any other programs that you guys have questions about? Any other questions at all? Okay.
Yeah, they're the house of the trust.
Yeah, that's there's two conflicting rules there. If your home's in a trust, you gotta take it out, apply, then you can throw it back in and let the spouse just disinherit the spouse. There's some great Medicaid planning strategies for that to think about. If you have just anyone with a will that has just have one paragraph, one sentence even that says, if any person in my estate is disabled, they don't inherit the money, but instead it goes into a special needs trust. That one sentence is the reason I get so many problem cases, is because we don't have it. If we just have that, it saves it for your spouse even. You can actually disinherit a spouse and put it into a trust so that it sounds mean, but you're getting it into a trust, you're putting it in a trust for the spouse. They're gonna use it, they're gonna stay on Medicaid, and they're gonna have more money to get a better room and get their hair done and their nails and maybe a nice massage every once in a while.
Yeah, right.
So
Yeah.
it's one sentence, Yeah,
So you've heard conflicting things with this, depends on what you look, like, as far as like. Medicaid, they're in a shared room, 9 times out of 10 for assisted living, things like that. Are there ways, some fiduciaries say, that trust can't, because Medicaid pays for, like, room and board, they can't use that money to buy up to maybe a private room.
as with all things with Medicaid, nothing's ever clear and there are always risks. And so one way around that is if, when I'm coaching for representing a fiduciary, I say, well, here's the risk and here's what you can do. And if we go to Medicaid and ask, I've had them say yes. I've had them say, yeah, that's fine. Go ahead. And now I got it in writing and I got it in an email and I'm saving it in my file. So if they ever come back, then I'm not my client, the fiduciary, is not responsible for it. When my client is the beneficiary, I'm always pushing the fiduciary to do what's best for my client.
Is that a decision or is it a trust decision? Because I've had the same thing where
Yeah.
the trust officers are like, oh, well, that I can't, even though it's like a special needs trust or something, like, oh, I can't use the money for the buy.
So yeah, there is, because, and the rule has changed recently, the rule shifted a little bit and got a little easier on this with as far as special needs goes, because it used to be in-kind support and maintenance or income to the person whenever we paid for housing. And so that rule lightened up a little bit in November of last year, as did food, by the way. You can pay for food now and it doesn't count against them. So the trustee can pay for any food and it shouldn't be a problem. So it is it's both, in short. It's a trust rule based off the POMS Social Security regulation. And it's a Medicaid rule itself too. If Medicaid was really strict on this, then yeah, they could say anytime you can't do that because that's income to him. If you paid $1,000 to get them in a better room, now their income went up 1,000 and now they need a Miller Trust. And then you walk through the Miller Trust analysis, and I still think you should be able to pay for that room, in my opinion, because it says there's 2 exceptions to that, and one's for your share of cost and care. So if you ask, I haven't had them say no to me when I've talked to them nicely about it, but yeah. Doug Fleener, I'm just joking. Doug just left that. He used to be one of the old DAGs there, but now it's Jeremy Youngren. You can talk to some of the folks in eligibility. Like Callie has okayed it for me before. Who has anyone else okayed it for you? But Jeremy has okayed it for me before. Callie has okayed it for me. But I also don't want to abuse them and have everyone start emailing.
It's only when you have something that's a problem that you.
There's a new attorney general, his name's Lauren, gosh, what's his last name? Anyway, a new guy, Lauren Messerly is his name, and he seems like he's got a pretty decent sized heart. He's been pretty easy to deal with. He'll knock in the estate recovery stuff. He knocks off a few bucks here and there just to be nice. And I think he'll be easier to work with.
Reasonable on funeral expenses.
Yeah, I know. A $2,000 headstone shouldn't be too much to ask, you think. But any other questions, concerns? Oh, go ahead, Mary.
A unique circumstance, so in a certified, it's kind of a res-hab situation in community homes. And I have a client who actually has 2 bedrooms in this, and the trust is authorizing to pay for the extra bedroom because it's his office.
Yeah.
And so there's no issue with that, correct?
I mean, so again, there's so much gray area and there's 2 positions you could take on this. It's one of those things that I would say, I would think that is not a housing expense. If it's an office, that's how I would say it. But there's just reasonable arguments that can be made on each side in these. And
Is he making money in that office?
Yeah, yeah.
No?
Well, I mean, still, but what if I rent, it's no different, say if I rented a gym membership. Like I have this space that I go to work out. It's not, I'm not living there, I'm not sleeping there, but it is a space. And so I could make that argument, yeah. And my default programming is to give more to the person, that's the individual with special needs. And to kind of take that position, but I can see how Medicaid could balk at it.
Well, the trust says this is quality of life.
Yeah.
It's definitely a quality of life.
Mhm.
I agree.